So as a bit of background for me, so I've been at LSA for 6 months. I came from one rehab, so I was there for 8.5 years. So I've been on your side of the table. Stacey and I joke that we've swapped positions. And then inpatient rehab before that. So I guess had the opportunity to come here also being from a participant and a provider perspective, I guess, and sort of see how it works. And it's definitely been interesting, I think, to see have an understanding about the paperwork and the rules and all the stuff that's needed, and some of it has clicked for me when service providers were asking me questions as wanting to clarify information as to why they're actually doing that. So I guess we wanted to give a bit of an overview of some stats from attendant care participants. And when we look at attendant care, as Claire sort of touched on regarding the strategic themes, I guess really relevant is that person-centred treatment, care and support, but also a sustainable scheme ongoing for participants, current and into the future. And if we look at all the different areas that LSA funds, so attendant care and support services, hospital, medical, AT, home mods and rehab, so allied health, attendant care accounts for 80% of what's being funded. And some recent stats, so in the last 12 months, 150 participants have access funded attendant care supports, so 35%. 120 participants have accessed domestic support, so 27%, and then 140 participants have accessed gardening or home maintenance, whether that be like an ad hoc gutter cleaning or an ongoing support for them. So I guess just trying to capture that's a big part of what LSA and the budget has been funded. And then I guess a little bit about how is a care needs assessment that you guys are doing and the recommendations are used in practice. So I guess we're used by service planners to be able to engage treatment, care and support. And it's really important that we reinforce the need to make it clear to a service planner what is motor vehicle injury related and how it fits within the LSS rules for service providers. For service planners, to provide that written justification. And that was probably something that I really noticed coming in about how they're having to document. So those service contracts that we see as providers, the whole of the background information that has to go in to be able to justify that. So I guess that opportunity to make that really clear from the information we're getting from providers. Thinking about projected function and possible ongoing improvement, and that has that impact on the recommendations as part of the care needs assessment. So as Claire was touching on, considering the timing of the care needs assessment when you're completing with the participant and highlighting the assessment as of the current care needs. So depending on where they are in that with that acute transition or living life, these may change over time. And I guess trying to consider that capacity building approach with supports. So the therapy intervention, AT, home mods, etc. And as Claire highlighted, the importance of setting the expectations from the beginning in those conversations, that it may not stay the same as for that ongoing. And, you guys as assessors are in that key, I guess, role to be able to highlight when you're discussing that with participants. Looking at assessed care needs versus gratuitous or informal care and the recommended hours. So documentation of gratuitous care is really important in those care needs because it really gives us that complete picture of what someone's care needs are, and it can assist us to understand the complexity. However, just wanted to highlight the family are not expected to provide care. So, you can have those conversations and maybe be willing to try it, but it's really important that we have that clear understanding of what's involved. And it may be that less hours are implemented to attendant care providers because of that, participant choice, etc. But if we've captured everything that's clinically required, I guess it gives us some information to be able to refer back to in a timely manner if things are going a bit off track or we need to review those things. I think you can consider alternatives. So other factors to consider and distinguish between might be age-appropriate care and support needs or function, the impact of ageing, the impact of non-motor vehicle injury related diagnoses, whether there's other agencies involved, so My Aged Care, NDIS, etc., whether recommendations, some therapy recommendations, so particularly, I guess, sort of in that living life, as well as therapy blocks, or as there's a task that you have identified through the care needs assessment that want to advocate for some therapy intervention. And then obviously any assistive technology or home modifications. And I guess making it clear in terms of the support worker ratios. So there is that clear documentation when it's required for 1-to-1 or 2-to-1, whether it be behaviours of concern, etc., or high physical needs. But also in the instances where SIL may be considered, looking at 1-to-2, 1-to-3, and what tasks there might be to shared, and what it might look like. So I'll go a little bit more into SIL in a minute, but I guess that's that importance to get that clear picture from you guys. I also just wanted to outline, I guess, a bit of the process in terms of LSA engaging attendant care providers, because sometimes we can think about the timing of when a care needs has been asked to be done and then actually the change of when it gets implemented. And so I guess service plans will put out an expression of interest to the attendant care panel of providers that we have, and then they'll provide the participant with a choice of around 3. Just flagging, we are currently undergoing a new tender process for attendant care providers. So there's a list on the website, but we'll be looking at expanding later in the year. We need to consider recruitment. So often you may put an expression of interest out to providers and they'll say, yeah, we can take that on, but then they've actually got to recruit staff behind that. So, it's a 4 to 6 week process, ideally, sometimes longer. Okay, so I guess just when you guys think the care needs are coming through, it may not be that we're not actually implementing it a little way down the track, but that's that reason why with those complexities, and also location, rural, etc. We do have a preference to work with panel providers at the LSA because they follow the LSA rates, but also, as Claire mentioned, I guess we've got those working relationships. So we're really working on building, and I'm meeting quarterly with those panel providers to have the opportunity to put a face to a name and really create that communication back and forth. We don't work with sole traders, so I guess just wanted to flag that because often, I guess people coming from other schemes, in particular NDIS, and you've got your higher up Mabel, those sorts of things. LSA don't work with sole traders, so just wanted to flag that with you. And there is also a non-panel provider process. So we talk about preference of the panel, but there is a process, I guess, if it's deemed that it's a panel provider or we don't get any response from our expression of interest, that we can explore other providers, and there's a procurement process around that. The other thing I just wanted to use this opportunity to think about, which probably I didn't have as much of an idea about or didn't consider, is the SHADs, so independent care providers, and the impact from a rostering perspective. So I guess just defining what their shifts look like, and so that's something definitely that we're working with the attendant care providers around. So a day shift means any shift which commences after 6 a.m. and ends before 8 p.m. An afternoon shift means any shift which finishes after 8 p.m. and at or before 12 midnight. And a night shift means any shift which finishes after 12 midnight or commences before 6 a.m. And the key thing for that is that if a support worker has a shift, say, from 2 till 10, because they're ending after 8 o'clock, that whole shift gets classified as an afternoon shift, so all those rates are paid at that afternoon shift rate. And so I guess the impact we've been looking about the cost of the scheme, if it's clinically required, absolutely, more than happy to look at that and provide that for the participants. But I guess as an example, I was talking to a service planner the other week, and we were, she said to me, the service contract's blown out and they're charging this really high cost. And we worked out that the support worker was hanging around because originally it was indicated that they needed to stay with the participant until their son got home from work, which was at 8:30. So there was that half an hour. So they were there from 1 o'clock. They were staying to 8:30, and the whole shift was getting paid at that higher rate. But actually asking the question, this participant could be left alone for periods of time, was getting left alone on the weekends, etc. And it was just a communication. They're like, oh no, I'm fine, because they were just sitting watching TV. And so it allowed us to go, okay, no, the person could actually be left alone from 8 o'clock. They were happy with that. And the long-term plan for this participant is to reduce their attendant care over time. So it was working with the treating OT. But I guess just wanted to build your awareness. So obviously if it's clinically required, but they're the sort of things that I guess we're having to liaise with, also with attendant care providers and how their rostering might work.
It is an interesting one, isn't it, about if someone needs help to go to bed, and then it's like, do you want to go to bed at 8 p.m?
Yeah. And they feel that pressure.
Yeah, they
Like,
do.
no.
Yeah, they do.
Yeah.
And for some people, they're exhausted by that time, and yes, that's reasonable, but for other people, that
They don't want
they feel like children.
Yeah.
And we absolutely want to, have a person-centered approach. And if someone has to go to bed at 10 or 11,
That's fine.
it'll be fine.
Yeah. It's more about that conversation, I guess, because it just ends up happening that there's little things that pick up, and if we're looking from a sustainability perspective and those overall costs, things to consider. And then just want to talk a bit about from a housing and accommodation participants perspective. So currently LSA funds SDA for 15 participants, for those people with high physical support, fully accessible and robust SDA. So only 3.5% of participants if we consider the whole number of the scheme, but it's a significant financial impact on the scheme over a participant's lifetime. So for this reason, the participant accommodation needs continues to be reviewed over time to ensure funded services are in line with the clinical need, as well as exploration of other options. Okay, so community housing, etc., which we'll go to in a minute. And then transitional accommodation is funded for participants where the participant's normal place of residence is temporarily not appropriate to meet their needs related to the motor vehicle injury. So, for example, when participants are awaiting major home modifications to their own home, or for accessing intensive rehab in preparation to return to rural or remote areas. So we sort of just talked about what LSA will fund. So, as I said, the transitional accommodation is short-term SDA. So LSA can fund SDA for participants who require specialist housing solutions to assist with delivery of supports that cater for their extreme functional impairment. So that includes behaviours of concern or very high support needs, physical support needs. So where their usual place of residence is not accessible and can't be cost effectively modified due to the motor vehicle injury, or when modification of a new home is not feasible. Okay, and then the other accommodation is respite. So they'll fund respite for not more than 28 calendar days over a 12-month period, and the period is short-term for no longer than 14 days at any one time. The accommodation assessment form, we have a form that's often completed in conjunction with a care needs assessment for service planners can provide this to you. We're just going to show it, I guess. The accommodation was originally part of the care needs assessment, but when that care needs form changed back in October-ish, it was removed because I guess it was identified there was participants that weren't needing that, and so it wasn't required. So the decision was made to sort of separate that out. So I just thought we'd show that for you guys. So it's similar to the information that was previously as part of the care needs assessment. So I guess just sort of highlighting that all accommodation funding is subject to review against the necessary and reasonable criteria, and therefore may not be supported on an ongoing basis if the participants' needs change. So as we highlighted before, the cost of the scheme, like what are the opportunities, I guess, for us to review that? And that, I guess, is just important for you guys to be aware, once again, those conversations that you might be having with participants about accommodation, that, this is always under review. And also just flagging that the LSA require participants to make a reasonable rent contribution, as it's deemed this is an ordinary cost of housing, etc. So that we all have to bear, except in the stage of such as transitional housing, or transitional accommodation where, for example, home mods are being done to the person's residence because they might be paying mortgage plus, etc. So just want to talk a little bit of the housing pathways, I guess, to look at. So there's obviously private, so there'll be private ownership or private rental, public and community housing. So we've been working quite closely with SA Housing to try, I guess, and get an understanding in terms of processes, because we know there's a lot of pressure and out there in the housing market and to try and get more specifics. And so they've identified some like a housing needs assessment form that they have that we can utilise to outline, I guess, more specifics around participants' housing needs, can identify quite clearly that LSA is involved so that they will fund home modifications. So if you're looking at a community provider, it allows them to understand that they're not going to be responsible for that funding. So I guess we're sort of working particularly for people coming out of hospital and making sure that that is also completed so that we can advocate for that. There's SDA, which we touched on, and I'll touch on a bit more in a minute. And there's also obviously SIL that we are aware of in the housing market. So the preference is to have, for LSA, is to have different providers for housing and attendant care. And this is to maximise housing stability and capacity for choice and control for the participant with the attendant care provider. So we don't want a there are some cases where SIL has been considered for some participants. However, it means that their housing is impacted, and if they're having an attendant care relationship and they find the attendant care provider, there might be some breakdown in that relationship, etc. It means their housing becomes at risk because we can't just get another provider to come in for that. So that is definitely something that in some circumstances may be considered, but not what we focus on. And then also the complexity with housemate matching that comes around that as well. So in terms of home mods considerations relating to long-term housing planning, so LSA will consider funding major modifications to a public housing property, for example, to enable stability and assist in management of accommodation costs for the participant's lifetime. So those participants that are in SDA is also a requirement that they're registered for public and community housing as well. Because obviously from a cost perspective, it may be quite a big upfront cost, but if we look at the life of the participant overall.
Can I just ask a question, Hayley? So the situation with rent, so say if we've got a participant who was normally living in their own home with their partner, for example, and they've got a mortgage there and the partner's remaining in that house, and then the participant moves over here into SDA, there's an expectation that they're paying rent over here in SDA. And they've left the, kind of cost burden at home with the spouse and kids over here. Is that how it works?
In
theory, yes.
Yes.
Yeah.
But I think, and I'm sure we do have participants in that situation. I'm just trying to think. That would be something we would work through, and if there was.
That could very much destabilise the family arrangement.
Yeah.
And I think those sorts of things, LSA, we can talk it through, I guess, to look at all the differences. And I know there's one at the moment that I'm talking with a service planner. It's a young spinal cord injury. Their plan was to have a family, but he's high physical needs 24/7. Their plan was to build a home, but she's caring for him, and then in terms of eligibility around that. So, a lot of this stuff is not black and white. And I guess once again highlighting that needs change over time. And it might be that someone goes into SDA, for example, like that sort of situation initially for a period of time, but it's an opportunity for us to continue to review that over time and how that might work as well.
Thank you.
So when we think about SDA, obviously there's design standards that LSA and the accommodation form has those listed, because it once again gives us some prompting to think about what the accommodation may look like for the participant. The 4 design categories are set out under the SDA rules from the NDIA. Improved livability, so incorporating a reasonable level of physical access and enhanced provision for people with sensory, intellectual and cognitive impairment, and the environment responds to the needs of a participant's physical or sensory needs. Looking at fully accessible, so designed to incorporate a high level of physical access provision for participants with significant physical impairment. Wheelchair access indoor and outdoor, might have height adjustable meal preparation areas, power supply to doors and windows for automation. You've got your high physical support, so that incorporates a high level of physical access provision for people with a high level of physical impairment and requiring very high levels of support, including provisions for ceiling hoists, AT-ready, widened doorways, emergency power solutions, heating, cooling and household communication. And then robust, so incorporates a high level of physical access provision to be very resilient, while reducing the likelihood of reactive maintenance and reducing the risk to the participant and the community, including high impact wall lining, fittings, fixtures, laminated glass, soundproofing, secure windows and doors. So an LSA participant must be assessed as requiring high physical support or robust needs to be eligible for SDA that cannot be addressed in standard housing solutions. So SDA may be funded while housing pathways are considered, again in consideration of sustainability of the scheme, but also to empower participants to have their own home. Okay. So the other thing, I guess, in terms of consideration of sole occupancy is something that comes up. So I guess, once again, outline the complex needs related to the motor vehicle injury, if we're advocating for that sole occupancy, and, for example, behaviours of concern. And I guess in terms of being able to outline for that, a lot of these complex participants do have other funders involved. So there are times when agreements are made between other funders, so with LSA and for NDIS, for example, of co-contributions to funding for other disabilities such as mental health diagnoses. So having a real clear understanding of what is motor vehicle injury related allows us to be able to have those conversations. And LSA is actively creating links with providers, and many attendant care agencies themselves have formed active links with SDA providers, etc. So, for example, sometimes an expression of interest might go out to an attendant care provider looking for SDA for someone that's discharging, and they've already got those links as well. So we'll inquire from that perspective. The other thing we wanted to introduce today was travel assessments, and we've given a draft copy of what has been proposed out on the table today. So they're used to and some of you may have already seen this as well. So they're used to outline necessary and reasonable expenses of support and attendant care for a participant when they're away from home. So, for example, going on holiday, but also in recent times identified from overseas repatriation. So they're wanting to return back to their home environment, but they've had the accident here in Australia, in South Australia. And so what does their care needs look like in terms of that travel to be able to return home? So the form outlines attendant care support when away from home, including travel to and from the destination, changes to their existing service delivery due to accommodation in the environment, the unfamiliar surroundings, unfamiliar routine or need to access additional AT, and what are the expenses related to this. We also need to consider what other supports are available to support the participant when they are travelling. So, for example, Adelaide Airport have their Hidden Disability Sunflower program. So there's programs that are out there, and I guess providing that justification about what could they access and then what is the need that LSA, because it's motor vehicle injury related, that means that we need to consider. And I guess just highlighting for overseas travel, the LSA generally requires receipt of this assessment at least 28 days prior to them going. So we thought we could have a bit of a look through, as I said, sort of draft format, and we'd be keen for your feedback on that as well.
Have you got a limit on how many episodes of travel they're allowed to have in a year?
To look at travel around holiday, it's like annual leave. So like all of us get 4 weeks leave. So that would be consideration of within normal, what's reasonable. Yeah.
It's like, because I know I've got a client, they're not an LSA client, but
Yeah.
got a client that goes away 3 times a year for a week at a time, or
Yeah.
a month at a time sometimes. So,
Yeah.
yeah, just thinking around that for some people where it's more normal that they travel more.
Yeah.
And what that
And once
means.
again-
Another one actually is dogs. So they travel to say a lot to show their dogs.
Yeah.
So, yeah, just wondering if people in that kind of situation, what that would look like.
Yeah. So I guess is that in that sort of 4 weeks thing, but I guess that's again that would be for an open discussion as to what was needs reasonable and necessary. And just to finish before some lunch, so I guess often where our involvement is around those sort of complex cases, and trying to identify some of those complexities can include participants with pre-existing or dual diagnoses, pre or post the motor vehicle injury, and the impact of ageing related that may occur. I guess in terms of consideration of the pre-motor vehicle accident function and care needs related to the other conditions or diagnoses before they had that injury. Like we talked about, trying to tease out what is related to the motor vehicle injury, and that can take some time to be able to do that. Considering the functional change post the motor vehicle injury to the other related conditions as well. So just sort of acknowledging all those complexities around that. Again, what other services and funding bodies are involved, then what can the participant access? But also thinking about any unmet needs prior to the motor vehicle injury, such as mental health, social housing. They may have been eligible for NDIS, but not actually accessing anything from NDIS, or the complexities around that as well. And so I guess trying to help us understand a bit of a baseline of what the person's function was prior to the motor vehicle injury and how that has changed. And yeah, so just wanting to acknowledge that, sort of that complexity around that. And we were sort of trying to think of some examples, and one person we're sort of working with at the moment, a 34-year-old Indigenous woman who sustained a TBI back in 2018, who's high-speed MVA, also has orthopaedic injuries and pain, etc. as relation from that. Previous medical history of mental health and substance abuse. So you're looking at the team around her. You've got an attendant care provider providing 2-to-1 support 24/7. You've got accommodation. She's currently in a SIL arrangement because previously she was in SA housing property. However, there was destruction to the property and a service exclusion was put in place for 12 months. So that impact from there. You've got the guardian who's a family member. You've got PBS provider. You've got OT providing home safety, activity engagement, and then you've got external agencies. So you've got the public trustee. You've got SA housing. A referral's being made to the ENU, so exceptional needs unit. SAPOL are involved. Community mental health, and ORS. Yep. And so I guess just recognising from an OT care needs assessment, you're going to know who it is, enabled LSA to fund attendant care and support worker training for behaviours of concern and looking at that activity engagement. It allowed us to advocate to SA housing and community housing providers around what her current care needs were and aiming to try and create that future stable accommodation for her, and it enabled us to advocate to the ENU to get them involved because this is the exceptional needs and the complexity of social around there. So I guess just sort of highlight there's often a lot of people involved, but the care needs that you guys are able to provide at the time to see what that looks like, that information is really utilised across that board and those meetings that we're attending.